Good evening. So we will start now the last topic of this webinar, which will talk about autologous blood donation. When I prepared this topic, I had several questions while presenting about preoperative autologous blood donation today. Why was PABD frequently proposed in the 90s, begin 2000, and which are the pros and cons from the literature? Now it's also interesting to know when is PABD actually recommended and how to increase the efficacy of such transfusion protocol. What are the current limitations in Belgium? And to conclude, which message can we give to the patient who asking about this transfusion protocol? So autologous blood donation happens when a blood establishment collects blood from a person and stores it for him for a planned procedure. It is organized around 6 to 4 weeks up to 72 hours when it's in a preoperative setting before an invasive procedure carrying a certain risk of bleeding. Despite ABD is rare in our daily practice, it could still be proposed to some patients, and a few wants to know about the feasibility of this allogenic transfusion alternative. These might be suspicious about the global risk of allogenic blood transfusion. Some of them do not want to have COVID-vaccinated blood. How to include these patients in such blood program? What are the exclusion criteria? What are the adverse reactions? And how is PABD realized in practice? I hope that this topic may answer to some of these questions. So why was PABD frequently proposed in the 90s, begin 2000? At that moment, there was a widespread concerns due to disease transmission to patients. In the 80s and 90s, there were tens of thousands of patients across European Union who were infected with HIV, hepatitis B, hepatitis C, and other pathogens. And this was due to transfusion of blood components and treatment with plasma-derived medicine products also. This leads to a high political and social impact with wide reports in court cases and government inquiries. So since 1997, we have the Treaty of Amsterdam, who gave the European Union the legal competence to set minimum quality and safety standards for substance of human origin. Of course, member states make more stringent measures if needed. So here you will find some difference in the transfusion chain when community blood donors comes when compared to a patient who needs to have an autologous blood donation. So for community blood donors, an important point is that they are voluntary and unpaid donations, because they will fill up a questionnaire who is an important part of the safety of the blood that we collected. And after he passed this questionnaire and physical examination, he will be able to donate his blood, which will lead to some blood testing, and they will check biological criteria and other infectious disease, and to see if the patient may continue to give blood, or if we have to exclude him for safety reason or for his own safety reason. So when the blood is then processed, stored in the blood establishments, depending on the blood bank of the hospital, they will be delivered and transported to the blood banks, who, based on a blood order for a patient, make the required pre-transfusion test. And this will be then, this blood will then be distributed to the unit where the patient is, and the modality of transport may vary from one hospital to another. What is important is that for autologous blood donation, it is important to have a specific indication to require such a transfusion program, and the physician in charge of this request should have biological criteria checked, and then he will have to contact the physician who is responsible for blood collection in a blood establishment. And based on the physical status of the patient, the medical record, and the blood test realized, the physician may propose a PABD program, which with a frequency of blood donation and a blood volume that can be collected, which may differ depending on the tolerance of the patient. And this is really important because community blood donors have really a maximum of of blood donation per year, and for PABD we have much more donation in a short period of time because we have to do it before a surgery, for example. So these blood will also have the different testing and processing, but they require totally separate labeling and storage in the blood establishment, but also in the blood bank, and the traceability must be very high to be distributed to the patient whom it's on his own blood. So when we look back about the request, we have to assess the risk of adverse reaction and risk of blood collection transfusion from each patient who will have PABD, because they may be much less healthier than the community blood donors. So adapted protocols will appear and may differ from one patient to another. This is already a difference that might lead to much more time in the organization of PABD and to assess if the patient tolerates well and has no adverse reaction. So as I already said, this separated labeling and storage is very important, as it may lead to errors at the bedside, even if it's autologous blood donation. And you have to be very careful that you don't transmit to another patient this autologous blood. And therefore, some PABD programs recommend that there are the same exclusion criteria for homologous blood donations and for autologous. But this might be, of course, very well discussed if a patient has troubles to find his own blood compatibility. Evolution in practice. In Canada in 2007, there were still 5,000 ABD per year, and this number decreased to 5 ABD in 2019 and only 2 in 2020. Only 2 blood establishments are available for ABD. In Belgium, we have 4 blood establishments that are able to propose PABD, but the frequency is very rare and reserved for specific cases. Some of them have not carried out PABD since years. Inclusion criteria for PABD. So begin 2000s, there were a difference in the inclusion criteria for PABD between countries. And as you can see here, what was important is, of course, the risk of transfusion in elective surgery above or equal to 10%. But they requested also that there were the same transfusion protocol for ABD for autologous blood and allogenic blood. In the US, they proposed they needed also to specify several weeks before surgery. Australia wanted to have more higher chances of transfusion with a life expectancy long enough to be impacted by blood transmitted infection. And for France, there were other examples, 3 to 6 weeks before surgery, a risk of bleeding over 1,000 of a liter. And so this is all examples that can be helpful to assess which patient could be included in such a program. What are the contraindications for PABD? So we have the European Union who gives this quality and safety recommendation that we follow in Belgium too, and we had also the royal decree before, as you can see, that already gave some recommendation. But currently we follow all the European guidance. And as you can see also in the selection for blood donation for homologous blood, we talk about the questionnaire, so it's important that the answers are very honest, and also from the partner of this blood donor. Clinical examination, you need to have also, you have a limited age, limited body weight, a minimum of body weight. And so all these aspects are really securing the blood donation. But for autologous blood donation, the criteria for the patient should not be as so severe, because you do it for another reason. You may have older patient, hemoglobin can be lower, white can be lower, but you have to discuss the risk of adverse reaction, and you might not take more than 10 milliliter per kilo or around 12% of circulating blood volume. So you have, of course, exclusion criteria: severe cardiac disease, some infection, blood infection, and acute bacterial infection. You will find in the European guidance more precision, but still it's not so much. So I try to find in Canada and France some other contraindication who might help us to select well the patient who will support it. So what are the pros and cons from the literature? So in the 90s, begin 2000, there were many studies on PABD, different surgeries and different protocols. It was really very difficult to conclude on the results, and the cost effectiveness on such a program was based only on cost per quality with avoidance of infection transmitted by blood. So when between 2000 and 2010, there were really concerns about the number of autologous blood units that were wasted. So the question is again about the cost effectiveness of such a transfusion program. So we had also more alternatives that improved in patient blood management, use of transfusion protocols, and a view of acute threshold for hemoglobin, and we discussed about acute normovolemic hemodilution, cell saver techniques that can be increased, and of course hemostatic drugs such as the use of tranexamic acid, which were very interesting for hemostasis in procedures carrying a high risk of bleeding. So improvement of the quality and safety of blood products also increased, and so the question was natural to ask which patient should benefit from PABD. There were less fears of the infection these last year transmitted by blood, and the reduction in PABD was clearly seen. But we should not forget that we still have sometimes problems, a shortage of blood products in pandemia, which may not allow to give all the patient compatible blood when they need many of blood products. It might be difficult to have in some really difficult shortage periods, compatible blood for every patient for elective surgery. So we need also to be very careful for rare blood groups and minorities, and this might increase with immigration. We should also not forget about the immunomodulation of blood transfusion and other risk of new pathogens that might be transmitted by blood in the future. So here you will find some variation in study protocols. First of all, I think we should redefine the definition of cost effectiveness, and this is something that is difficult to assess with the previous studies. So the use or not of transfusion protocols, that was really an important point that makes the conclusion in these studies difficult, because we all could see that transfusion protocols reduced the need of blood transfusion in a significant way. And we could also notice there were much more liberal transfusion for PABD, which should not be the case, in fact. In PABD groups, we had more healthier patients, so we need to be careful with comparison. And the frequency of blood collection could vary, and the timing before surgery varied also with volume of blood collected. This is something so very difficult to conclude in the results they give. Also, some of the protocols used are not cell saver or ANH, so it was not very well standardized. Not every PABD program screened also for iron status and compensated for iron losses. So we must remember that 1 blood of unit collected is equivalent to a loss of 200 to 250 milligrams of iron. And with a normal diet, it can take up to 6 months to restore it. So iron treatment is important in blood donation. And when it was available, the doses given were different. And when it was given an IV, it was only 200 milligrams at that moment that were available. So we had variation in dose of epiotherapy. They varied so much it was difficult to assess if it was a problem of the protocol or iron status or the contribution of the number of unit donates. So we had a really different response in erythropoietin levels that could probably be due to absolute iron deficiency and certainly to functional ID when iron loss was not compensated in such a short period of time. So we have a cost-run review of 2010 who selected 14 eligible studies based on certain criteria, and they concluded that after the trials of PABD showed a reduction in the need for allogenic blood. We had a relative reduction of 68%, but an absolute reduction in risk of allogenic transfusion was 44%, and the risk of receiving any blood transfusion was increased in the group of who carry out PABD. So there was evidence of significant heterogeneity for both of these outcomes, and the methodological quality of the trials was very poor, and the overall transfusion rates too high compared to what we do now. And so we raised really the question at that moment of the true benefit, and we should actually review it with a much more high quality trials and with a precise clinical endpoint, precise transfusion program with specific therapies to increase erythropoiesis. So as you can see here, we have some examples that were used in the cost-run review of the difference in protocol and iron compensation. So that is clear that it's not easy to conclude with such a difference. Let's talk a bit about iron deficiency. So iron deficiency may occur despite a normal pre-donation hemoglobin measurement, and PABD programs need absolutely to take into account iron status and iron loss. Iron deficiency has clinical impact on patients' outcome, not only anemia or transfusion. So I will present this publication made by the Belgian team from Professor BeQuinT, and it talked about the increased iron absorption during autologous blood donation supported by epeotherapy. So they had an interesting protocol which, for the study, which allowed blood donation, autologous blood donation, 3 times a week during 2 weeks. At each visit, that took 450 milliliters of autologous blood, and it was collected as long as hematocrit remained greater than 33%, with a maximum of 5 units donated. They used placebo or epeotherapy subcutaneously at the 3 first donation day, and all the patients received oral iron with folate from day 0 to discharge, and the surgery was scheduled on day 21. They had several blood samples at each moment up to 3 days after surgery and the day of discharge. So as you can see here, of course, not all the patients could give 5 units, but most of them could give 3 to 4 units, which is very interesting. In the placebo group, you can see that the volume collected decreases, but with epeotherapy, you increase the volume collected. So that is also an important point. So you can see that with epeotherapy, there's an increase in red blood cell mass produced compared when you have your own endogenous EPO for erythropoiesis. We know that blood donation increases erythropoiesis by inducing iatrogenic anemia, and as much as you donate blood, you can have a higher response to erythropoiesis. But this is much more increased with epeotherapy, and the 600 units per kilo were the best answers to erythropoiesis. So we can see also that this higher epeotherapy leads to increased volume on this picture. But when you look at the other results here, it's also interesting to know that these patients were in fact not anemic, and they had good iron status before blood donation. You can see that the stores were really good, and with all this blood donation, even with oral iron compensation, you decreased your iron stocks. And this is something we need to be careful when we do aggressive protocols. But you can see that the intake of iron is increased with eperotherapy. And this might explain also why erythropoiesis has a higher response with higher eperotherapies. So we need really to be careful of the risk of iron deficiency in such aggressive blood donation program. You can see that for the group with eperotherapy, these are higher iron stocks than with placebo treatment. So pros and cons from the literature. When we look back at what are the advantage of PABD, so clearly there's a prevention of transfusion-transmitted disease, and you have a prevention of red blood cells alloimmunization. You supplement also the blood supply by increasing erythropoiesis, and you provide compatible blood for patients with alloantibodies. You have also prevention of some adverse transfusion reaction, as it's your own blood. The disadvantage is that there's still a risk of bacterial contamination or volume overload for the patient who will be transfused, and it does not eliminate the risk of administrative error with ABO incompatibility. These are also more costly procedures in allogenic blood donation, and in Belgium the reimbursement price is lower, which is not normal. Wastage of blood that is not transfused is also a matter of concern, and we know that it can cause periodic anemia and increase the likelihood of transfusion, but it might depend, of course, on the protocol use, additional treatment to increase erythropoiesis and avoid iron deficiency. So you need sufficient time and organization to do it in an optimal way. So when is PABD recommended? We have patients here who will have not compatible blood, or their blood is not available. And these are rare blood group in minorities due from immigration, but it can be also patient with multiple antibodies against blood group antigens, or with antibodies against a public antigen of the red blood cells, and for whom we have no insufficient allogenic blood products available. So that's why it's really important that your blood group should be assessed in time before an elective surgery. We can also propose it to children, but we have to have a minimum of weight, minimum of blood collected, and it might be indicated in children who has to undergo harvesting of bone marrow, or in an exceptional case whereby suitable allogenic blood is not available for elective surgery. It is recommended that for these children we should use pediatric packs, but in Belgium we do not have this pediatric packs. We have only blood that is a minimum of 365 milliliters to obtain. We need to have 365 milliliters, so every child needs to have a minimum of white to allow this collection, of course. So we can collect red blood cells, and their storage can be is up to 42 days, and it can be cryopreserved in some specific cases. We have plasma that can be collected, 1 to 3 years storage when the temperature is under -25 Celsius degree, but it's not viral inactivated here. And for platelets, it's much more difficult to see if there's a good indication, because the storage at 24 degrees enable only a time to transfuse it during the 5 days after donation in Belgium and 7 days in other countries. So an important question will be how to increase the efficacy of PABD. You have to avoid the chance to waste this ABD, of course. So select the right procedure with a sufficient risk of transfusion. Around 10% can be taken, maybe higher, and risk of substantial blood loss. So we have sometimes waste up to 50%, even if the procedure is well selected, but it can reach 90% of waste when you choose for low bleeding risk, such as vaginal hysterectomy. So there's less, we need to be careful that with the improvement on surgical techniques, less invasive surgical techniques, these made the older proposition maybe not reliable, and each center should really analyze their own transfusion risk for different invasive procedures they're carrying out. So we should really propose such a transfusion program as far in advance of the surgery, but just remember that 42 days is the timing of red blood cell storage. So to allow, we need sufficient time to allow compensatory erythropoiesis to correct induced anemia. And for every autologous blood unit collected, there's a mean decrease from 1 gram per deciliter in hemoglobin and 3% decrease in hematocrits. And if the erythropoietic response to ABD is not able to maintain the patient's level of hematocrit during the regular interval, this might be a harmful transfusion program. So the previous rule, no predonation when below 34, might currently not be something that we will propose, as we really aim to increase hemoglobin over 30 grams per deciliter before surgery in order to reduce, of course, allogeneic blood transfusion. But this might be, of course, discussed for patients with a rare blood group and other indication of PBD. So appropriate patients, that is also the second most important part, is to select the patient who will really be able to do a good PABD program, because we have still 10 to 30% of chance to receive allogenic blood in addition to autologous blood. So critical factor to avoid this blood transfusion is the ability to donate the requested number of autologous blood in the transfusion program. So over and equal to 3 units are able to reduce 91% of reduction in allogenic transfusion. And when you reduce it to 2 or 1 unit or 0, your chance to avoid this allogenic transfusion reduced to 75, 48, and 12% respectively. So a total of volume of circulating red blood cells is depending on the baseline hematocrits, the sex of the patient, and its body mass. And of course, its ability to reconstitute the red blood cells collected at donation. This will be, of course, the answer to erythropoiesis depends on the rate of bone marrow activity, and repeated donation induced limited stimulation of endogenous EPO production. There is no influence on the interval between collection on erythropoietic activity, if it's recollection 7 days, every 3 days, or there in 15 days or every week. So this is not impacting much erythropoietic activity. The endogenous EPO response is suboptimal when the level of mild anemia is experienced during collection of autologous blood. And there's only a linear relationship between the degree of anemia and EPO when the patient is with an hemoglobin below 10 grams per deciliter. But this also might be affected by underlying disease. The use of EPO therapy that stimulates erythropoiesis in patients enrolled in PABD increases initial hematocrit levels and accelerates the reconstitution of red cells lost during collection. So this is important if you want to have a good blood collection. But we have to assess the risk of EPO and iron therapy. There are really criteria we should be careful if patient may receive EPO therapy or not. Whose medical conditions also increase the potential risk of adverse reaction to blood donation, such as cardiovascular patient. We know that both autologous and allogenic blood donation are associated with risk, and we have adverse reactions severe enough to require hospitalizations that are 12 times higher in the group with autologous blood than compared with the group of the community donations, which are healthier. So we have to be careful with sometimes for ischemic events. So if the risk of delaying surgery might be more detrimental compared with the risk of infection transmission via allogenic transfusion or risk of alloimmunization, we should advise to not donate autologous blood. Some suggestion to make it less costly is abbreviating the donor interview for autologous blood collection, and the availability of center transfusion risk stratification can, of course, reduce this time to assess the appropriate patient. Use only whole blood and discontinue maybe component production, but you have to be careful that the length of time of storage is reduced into 28 days for whole blood. And I'm not sure that we have whole blood actually currently stored in our blood establishment. Limiting the use of frozen autologous blood, because this was one of the aspects also that could be wasted, the most wasted. Applying the same transfusion guidelines for autologous and allogenic blood unit for infectious disease markers, that should make the process easier. And what is also a suggestion that really should be considered is the use of erythrocytes apheresis to allow 2 RBC units in once. This reduces also the number of costs for the analysis, as you do all the analysis for 2 units and not for 1 unit at once, and the number, of course, of donation. And combined with IV iron and high iatrogenic anemia at once, it might be interesting to see what will be the results of mast cell production if the patient has to be admitted on the day of surgery, what will be his hemoglobin iron status at that moment, with and without a perotherapy. So the current limitation is that we need for PABD efficacy supportive treatment for erythropoiesis, and we need also to keep iron stock at normal levels. And for preoperative setting in Belgium, we only have to reimburse for anemic patient without iron deficiency, and they will have to undergo only major orthopedic surgery. This should be reviewed carefully in order to increase safe access to epiotherapy before other major surgery. Currently, it's also reimbursed if there's shortage of blood, but you need to check medical status of the patient, because there's also contraindication and adverse reaction with epiotherapy, and you need to be careful that you give it to the right patients. So for iron, we have, of course, access to oral iron, but it's less optimal to restore iron loss on time, that we know it. So therefore, we have a new criteria since May 2022, which allows for preoperative major surgery with a risk of 10% of transfusion and hemoglobin below 30 grams per deciliter for women and men, with, of course, iron deficiency that is really well represented by saturation, transferrin saturation below 20%. But you have to start early to increase its effectiveness, minimum 4 to 6 weeks, to allow sufficient erythropoiesis by restoring his iron stocks. And you have it has to be associated with perotherapy if you use perotherapy to avoid functional iron deficiency due to intense erythropoiesis stimulation. So to conclude, there are only a few indications that recommend PABD. And this is really important part that we need to explain to patient who wants to know if PABD is feasible. Inclusion and exclusion criteria must be screened for candidates who have the right indication. And this needs to be requested by a physician, and as already told, it needs to be validated with a physician in charge of the blood collection. And they will validate a precise protocol for this patient. And you have to explain then to the patient the potential of adverse reaction during PABD, especially in sicker patient, and practical aspects such as the need for additional treatments to avoid iron deficiency and iatrogenic anemia due to PABD. So physicians in the preoperative setting need to assess the right patient, the right procedure, and see if it's really possible to optimize his PABD and provide him with the therapy, and have a look, of course, of the reimbursement criteria, because the patient might have to pay for it if he hasn't the right reimbursement criteria. But what is also important to inform to a patient who asks about PABD is PABD do not exclude the possibility to receive allogenic blood transfusion, but it reduces the number of allogenic transfusion. And some studies showed increased risk for PABD to receive also more blood transfusion, autologous and allogeneic. But in that point, it was really all the studies with more liberal transfusion and no transfusion protocol sometimes. So really, we might be not that worse now. Also, alternatives to avoid transfusion are available, and you have to explain to the patient all the different techniques that you might use to reduce the chance of any transfusion. And this will make PABD less worse, with a higher risk, of course, of wasting if you do it. So, to conclude, despite its reduced role in declining racial, PABD must be periodically revisited to assess its role in a changing environment. So just to comment, PBM Pillar 1 takes less organization manpower to screen and optimize periodic anemias and PABD organization. But since 2000, we have less fear for blood transfusion, more alternatives and progress in the different invasive techniques. And this should not reduce the importance of optimizing patients before surgery and also after. And since 2022, we have a new reimbursement criteria for IV iron before major surgery. So please let's improve again awareness of Pillar 1 and make a really difference in transfusion of allogenic blood. So I have a special thanks to the Belgian Blood Establishment concerning position about Q&A autologous blood donation in Belgium, and also Jana van den Broek for support in some images.